On behalf of the American Association of Kidney Patients, it's a pleasure to be here today. And I'd like to provide you with comments and candid feedback on the dust-up regarding the actions of your organization and CMS. I appear before you as the Chair of Policy and Global Affairs for the American Association of Kidney Patients and a former president. We are the largest kidney patient organization in the United States, and we've been proudly independent since 1969. I also appear before you as a kidney patient of 46 years, 26 years out on a kidney transplant after 3 years of dialysis. Since my kidney transplant, I've taken over 160,000 pills for immunosuppression. And so I know this issue rather well and the challenges that come to my medical professional teams when it comes to monitoring my health and those of my patient colleagues around the United States. Over the past several months, we've been highly involved in this issue, raising it to the attention of appointed leaders and elected leaders and the media in the US. And the reason why we have done that is because the actions that were taken stand in such stark contrast to American consensus bipartisan policy regarding transplantation and better kidney health. And the reason why I put this out to you, quite frankly, is because I've had the honor to serve under 4 US presidents and 4 governors here in the state of Virginia. I understand what it means to manage healthcare costs from a government perspective and some of the blunt instruments that can be brought to bear to do cost control. But some of those are just simply not patient-centered and they're not intuitive. And on this particular measure, it is such a miss for where we are in the United States right now on kidney health. I want you just to consider a few points of the past decade. In 2013, we were able to achieve policy in the United States Congress that allowed the first HIV to HIV positive transplants, a long-awaited goal and aspiration for the HIV community and all patient advocates. In 2016, the White House held the first summit on organ transplantation, and AAKP was a proud partner in that effort with the administration and with all the related kidney organizations in the space. In 2018, we worked closely with the U.S. Department of Labor to create better protections for living donors to encourage more living organ donation in the United States. And we're happy to see that came through. In 2019, we worked very closely with the Department of Health and Human Services to advance the American Kidney Health Executive Order. And that was a bipartisan executive order that stands to this day that prioritizes kidney transplantation as the best therapy for those who have kidney failure. In 2020, we worked with the US Congress and the White House to make certain that immunosuppressive drugs, which had been covered for only the first 36 months, were extended to lifetime coverage for patients in the event that they had interruptions to their insurance. And this year, as we have for the past several years, we are fighting right now on Capitol Hill to extend greater protections for living organ donations. And our organization has sent thousands of letters to Capitol Hill, Republicans, Democrats, Senate, House, encouraging greater protections for living organ donors. Why? Because it is the policy of the United States government to increase organ transplantation in the United States at a couple of levels. One, you have better outcomes when you have an organ transplant, especially a kidney transplant, than living life on dialysis. Right now, the mortality rate on dialysis is 50% at 5 years. Think about that. The cost of dialysis is over $30 billion a year. Think about that. What's not included in that figure is the disability payments that the US taxpayer pays for, because when you're on in-center dialysis, for the most part, you're disabled. And so across that spectrum of time in the past 10 years, the other things that patient advocates and medical professionals, including transplant surgeons, have fought for are greater innovations in making certain that those who have their transplants and patients who act responsibly can keep them longer. This is very important because right now, the clinical endpoints for determining the efficacy of transplant medicines are 20 and 40 years old. The FDA has failed to approve a new co-primary clinical endpoint for transplant drugs that checks and sees and tries to determine long-term efficacy and the reduction of side effects, including those side effects of transplant drugs, which are nephrotoxicity. So when you put this stew together and you look at it as a patient and trying to advocate for patient-centered medicine, all the horses are going in the right direction for transplant policy in the United States. And then up pops something like this from your organization, which, to be honest with you, is you should call it what it is. It's not a clarification for coverage. This is a blunt instrument of cost control. It's what our organization calls government determinants of health. Now, while that might sound kind of harsh, it does point to the factor that the government is making decisions here through a contractor that directly impact patient outcomes. If you cannot celebrate the innovation that has come from molecular diagnostic testing and understand what that means to patients in terms of avoidance of biopsy and the many complications that can come from that, you simply do not understand this issue. It is simply not an issue of cost and utilization. You're talking about outcomes of people who have been lucky enough and fortunate enough to get a transplant, and you're ultimately talking about how you value those who have offered an organ to save a life. If you're not willing to stand up and say that the flexibility needed to surveil those patients, to make sure they stay healthy, and to make certain that those who have organ transplants can continue to work for those who have returned to work and provide for their families, and understand the central role that diagnostics play in that, and how that is a tool that we trust our surgeons and doctors to use wisely, then you just simply don't understand this issue, and you really do not understand the progress that has been made in American kidney health. I'd like to add one other quick point here, which is this. We understand you're in a difficult position because you're a contractor to CMS. Ultimately, CMS bears responsibility for this. But to be perfectly clear to everyone who's listening, you have heard that there's not enough evidence. You have heard this is contrary to medical expertise in this field. But this is the most important thing. The onus should not rest on patients and patient advocates and transplant recipients to move to reverse this policy. The onus rests with CMS and those seated in the room who made this decision to do the right thing, be patient-centered, and wise up. Thank you very much.